Thank you for having me. It's good to see some familiar faces, and hopefully after this 1 hour session, I will have been able to help with an understanding of cartilage injuries in the knee. And so I have nothing personally to disclose related to the talk today. And just by way of introduction, I'm from Cleveland, Ohio area. I went to Denison University outside of Columbus, Ohio State for medical school. Did a 5-year combined internship residency at Henry Ford in Detroit, and then went back and did the sports medicine fellowship at Ohio State in 2008, 2009. With Jim Trussell's, was still there until prior to freshman year. And shortly upon completing fellowship, I started at Hinsey Orthopedics, and I know our group is well known to many of you. We have multiple locations, as many of you know. I go to our new Lenox and Joliet locations. So I'm in the south part of our group, and I've been there since I started. I personally live in Clarendon Hills, so I live closer to some of the offices up north, but I don't mind the commute down. I go to multiple different locations, predominantly in the southwest, although our group does own a surgery center in Westmont, and you can see those locations there. Throughout the last 10 years, it's hard to believe it's been 10 years in practice already, I have taken care of Joliet Junior College. Again, with the sports medicine fellowship, I wanted to take care of a team, and that was the first team I was able to take care of. We were super busy there until they got rid of their football program in 2011. And then I also took care of a local high school, Lincoln Way Central, and then helped out with the Joliet Slammers baseball professional team. So today, when asked what my topic might be, I had thought to myself, well, we'll switch it up because I think some of the other speakers had other body parts covered. And I find myself in a lot of depositions with many of you talking about knee cartilage injuries. And I wanted to try and go through some of the science and the anatomy, and ultimately I have a lot of cases here to show you, to illustrate some of the points, because it can be sometimes challenging to wrap your head around. So today we'll talk about cartilage injuries and defects, what techniques are available, what factors influence outcomes, and then turn into review cases. And so many of you know that there are two types of cartilage, one being the meniscus cartilage and the other being the end of the bone or the articular cartilage. And the meniscus cartilage has, and I'll turn around I guess to show you, has two meniscus pads. There's a medial or inner and a lateral or outer. And of course the articular cartilage refers to the smooth, shiny white cartilage that coats the bones. And in the knee, on this picture arthroscopically of the medial compartment, we can see the medial femoral condyle with perfectly pristine articular cartilage and a perfectly pristine medial meniscus, as well as the medial tibial plateau. So this is what we like to see when it comes to helping knees. The meniscus, as you guys know, has a blood supply. And the blood supply in the meniscus comes in from the outer part of the, I'm just going to take this off. So the blood supply comes in from the outer part of the meniscus, from the capsule. And so it's known to many as the red region, because the blood supply is better in that area. And as it diffuses centrally into the knee, we call it the white-red region and then the white-white region. And this is a better cross-section. You can see it's more of a triangular type of structure where the vessels again come in on the outer rim and then the blood permeates or diffuses centrally. And there's very little blood supply here. And that's why when tears occur, it's all about the location of the tear, the type of the tear. And many of the tears that occur in this area here, in the white-white zone, are not stitchable or repairable, and therefore they need to be trimmed out at the time of surgery. And so I'm sure by a show of hands who's had a meniscus tear case, probably everybody in this room. Very, very common injury. When people come in, we talk about options, and I've got some more later, but initially with a meniscus tear, we can talk about non-operative options, which include NSAIDs, physical therapy, a brace, or injections of cortisone, which is most commonly used. I'm happy to talk about PRP and stem cells, as the previous speaker did as well. I think that that's kind of a topic that's on everybody's mind lately. And ultimately, though, particularly for an injured worker, it comes down to an operative treatment where, well, we're in there arthroscopically, we have to decide, are we going to trim it or are we going to stitch it? And the vast majority are trimmable. There's very few that are stitchable, especially as we get a little bit older or as the joint itself starts to wear out. And so here's some examples of a meniscus tear, and I don't know how this projects up there, but you can see the medial femoral condyle. Here's our medial meniscus, and you can see this rip right through here. And so again, this piece of the flap of the meniscus is moving around, and that's painful. And I like to use the analogy of a bad hangnail in your knee. And so again, the logic of that analogy is that you would trim the hangnail out in order to feel better. So if that piece is flipping or pinching, thank you, in the knee, that can be very painful. That can also cause locking, clicking, and giving way. Here's another example, femur, tibia, another rib, and a meniscus. So these types of tears would be easily trimmable, trying to take out the least amount possible while maintaining the rest of the healthy meniscus. Another example of a trim, this is more of what we call a longitudinal tear. The tear itself sits right here. I would argue this is in a red-white type of zone. In this case, the biter and the shaver are used to take out this sort of half-moon sort of shaped piece of meniscus back to a nice stable border. So again, this type of tear can be painful for people as well, particularly in deep flexion, kneeling, squatting, as well as with twisting activities. This is a case that I did recently. This is not an injured worker, but an injured athlete who was 15. So had a sports injury, landed, and basically did what's called a bucket handle meniscus of his, or bucket handle tear of his meniscus. So here's the condyle. Here is the large fragment of meniscus that should be tucked in the back of the knee. This is a lateral meniscus in this case. So bucket handle, the analogy is it rips off the back. The piece flips forward, almost like a bucket handle if you went from side to side. And obviously this individual could not straighten his knee because this was stuck in the front of his knee, blocking the full extension of his knee. So this is an obvious operative case where when we're in there arthroscopically, especially in young patients, we want to try and save meniscus as possible. So we reduce or push the meniscus back where it belongs, and then you can kind of make out some of the suture material that I put in that anchors the meniscus back to the capsule. This was done all arthroscopically through two little portals with an all-inside repair technique that allows us to not have to open up the knee or do what's called an inside-out repair. For some of you probably had cases where, particularly before the devices really evolved, you would have to do a big open incision on the back outer part of the knee and literally pass the needles with the suture from the front of the knee and then fish them out the back of the knee and then tie the sutures back on the capsule to close everything up. So from a morbidity standpoint and a fixation standpoint, this technique has been great. So I do everything all inside. Very rarely, since fellowship, haven't done any open meniscus repairs. And so what to expect post-operatively after meniscus surgery. So after a trim, you'll be weight bearing as tolerated. Typically, crutches 1 to 2 days. Some people don't even use them. Some walk out of the surgery center. We definitely do some physical therapy to help get the quad strength back, especially for an injured worker trying to restore function, depending on their job demands. In general, it's a 4 to 6 week recovery, and again, I put very vague estimates in terms of MMI. Particularly if it's a healthy knee, it was a very straightforward partial meniscectomy. I think most of those patients get back to doing things pretty quickly. If we stitch a meniscus or we repair it, like I showed on that example of that young athlete, then we start to protect things. So we go non-weight bearing for 4 to 6 weeks with crutches. We typically use a brace like you see in the picture up there. There's physical therapy and then sort of a prolonged recovery because the quad atrophies. It takes time to get the quad back and obviously build back up the functional status. And this brace is just an example. It's called a T-ROM brace. It's called a hinge brace. It's got a little dial here that locks the knee straight. It can also start to unlock the knee depending on how you're progressing in the range of motion with therapy. So that's meniscus, and I think most people think that's pretty straightforward. And I don't want to spend too much time on that, but I did want to spend a lot of time here on the articular cartilage. And we all live in Chicago, so we all drive in Chicago. We understand the potholes in the winter and what they do to our cars and our tires. And in the knee, they're equally as disruptive. And so you can see here that obviously this photo of the pothole And then in the knee, you can see in this photo that we have exposed bone. So the articular cartilage on the condyle here is missing. And we've had a cartilage injury or a cartilage delamination where the cartilage has come off and now we have exposed bone. And so going with the analogy of the pothole, if we leave that alone and we don't do something to try and fill the pothole, we're going to end up with a cracked road that's irreparable down the line. So there are lots of things available for cartilage restoration. And the problem is once you get one of these, they don't heal. And again, once this cartilage starts to shear off or peel off the bone, unfortunately it doesn't kind of go back and stick itself back on. And there's no way for us to stick it back on there either. So once this happens, we have to find alternative ways to fill the pothole so that the road gets back to functioning well. And in general, with any of these kind of cases, we have to think about a number of factors: age, BMI, preoperative activity level, duration, prior surgery, ligament stability, meniscus status, and alignment. And I'll show a couple of examples of that later. But obviously, as you guys know, in the injured worker, it's occupation and job demands, time off work, restrictions. How is this going to affect this injured worker down the line, even if we have a perfect operative result? The problem is there aren't a lot of injured worker studies on articular cartilage restoration in the literature. So there are a lot of injured athlete cartilage restoration studies. Most notably is microfracture, and I know many of you have probably heard of this technique. And in the NDA, it's a very popular procedure, and there are a number of very high-profile athletes over the years that have had microfracture surgery that unfortunately were able to come back and play in the NDA. But it takes a long time to get them back, and they were able to get back, which is why when I talk to injured workers who I did microfracture on, I think to myself, if these guys can get back to the NDA, these injured workers should be able to get back to the jobs that they do. But it does take some time, because biologically we need that pothole to fill with scar cartilage. There are a number of studies that try and compare different types of cartilage restoration to one another. And again, I'm going to go over some of the examples here. Who has heard of ACI, or now MACI, Matrix Autologous Chondrocyte Implantation? Okay, so we're going to talk about that. But there's lots of studies available. So the bottom line is, when a patient comes in, we do a complete history. I do my best to document what the patient tells me, how they got hurt, what the mechanism of injury was, what they were doing. I try and be detailed. Inevitably, when we come to the deposition down the line, sometimes the details may not be as good as I hope they are, but we do our best to document a detailed mechanism of injury. Ultimately, as well, we need to talk about their knee. We need to figure out, did they have previous injury, previous surgery, and if so, what those were, because all of that plays into what is going on with their current situation. We have to do a good and thorough physical exam of the knee. And then I always get 4 standing x-rays in the office. There are lots of other x-rays done elsewhere, sometimes laying down. But we get them standing, assuming the patient can tolerate the discomfort of standing, in order to get a better idea of what the joint space looks like. So I think those are more accurate when it comes to making a decision on how to treat the patient. Ultimately, we come to an MRI. And the MRI is the key to trying to help figure out exactly what's going on. Unfortunately, MRIs aren't 100% perfect. And the quality of MRIs, depending on where they're obtained, can be variable. So many of the open MRI facilities that are out there exist for claustrophobic patients, and obviously they get a scan. But the quality of that scan, and I use the analogy of it's pre-HD TV versus the MRIs now, which I would say are HD TV, and they can be very grainy. So it's very difficult, particularly when it comes to articular cartilage, to make decisions on what is best for the patient when it comes to MRI, particularly a grainy or an open MRI. So many times if someone's had an open MRI, because that's where the primary care doc sent them, or the occupational doc sent them, we sometimes need a better scan. We need a better image, and so that's why additional MRIs are ordered, and more higher, what are called higher Tesla or higher strength MRIs. Of these 3 MRIs here, there's 3 examples of pathology. This is what's called a sagittal, or a side view of the knee. You can see the femur, the tibia, this will be the front. Here's the back, or the posterior part of the knee. This is the medial meniscus, and you can see this white line running right through the middle of the meniscus. So that would constitute a medial meniscus tear on an MRI. Here is a case where we have the femur. Now we're looking at this MRI from the front. So the front femur, the tibia. Here's the inner part of the knee. Here's the outer or lateral. So you can see that on the medial meniscus we have a nice triangle. On the lateral though, we lose the triangle, but here's the triangle. So this would be an example of a bucket handle tear where the meniscus is ripped off the capsule and flipped over into the notch. So that's an example of the young individual I showed you earlier. Last but not least, we have an example of an articular cartilage injury. So again, lateral, medial, the arrow is kind of pointing you to the area. You can see how bone on all these MRIs here are what I call charcoal gray. And over here on the medial side, we see this bone edema. Okay, so we see bone inflammation, bone swelling. And this is painful. And the reason, and that's kind of where there's smoke, there's fire, because down here, we kind of lose some of the articular cartilage layer. You can see these two indentations where those arrows are. So that tells me there's an articular cartilage injury that's symptomatic going on there. So when it comes to these conditions, again, physical therapy, cortisone, viscosupplementation, PRP, braces, NSAIDs. And in some cases, patients can benefit from what are called unloader braces. It's the spot where the problem is on the inner or outer. We can take a brace to try and improve the alignment or take pressure off of it. But ultimately, a lot of these end up coming to surgery. And so our options would be debridement or chondroplasty, microfracture, osteochondral allograft or autograft transfer, otherwise known as an Oates procedure, MACI, and then I put plus or minus an osteotomy. So debridement chondroplasty, it's very simple. We go in, we see it. This is typically a low demand person, usually older, going through some big rigmarole cartilage restoration procedure, and this type of patient typically not going to be overall effective. So we'll just do a debridement or chondroplasty where we take a motorized shaver and kind of try and smooth the edges down. Typically when you see things like these, there's other areas that are wearing out, and so again, going through a big procedure there is not worth it. Microfracture. On these cartoons here, we can see the knee, we can see a chondral lesion or a bare pothole. When we're in there, what we do is we scrape out the diseased cartilage, so we have a nice circle with nice vertical borders, and then the exposed bare bone. And then we take our awls arthroscopically where we poke poke holes into the bone. Those microfracture holes will stimulate bleeding. The bleeding will form a blood patch in this defect. The blood patch over time will form scar cartilage. It's not as good as what you started with, but it's better than nothing. And here you can see an example. So we're curetting a lesion. We're actually performing the microfracture with the awl. And then on the second look arthroscopy, you can see there was very good fill here of what we call fibrocartilage or scar cartilage. So this stuff's pretty durable. It doesn't last forever, but it's a very nice option, and it's a very easy option to do because this equipment is readily available in pretty much every operating room. And many times when we get into the operating room and we get the camera in, we are surprised by what we see because MRIs just aren't perfect. And so we have to have options available to us. Osteochondral allograft. Larger lesions, this is mostly the width of your condyle, significant bone loss involved. Maybe they've already had previous cartilage restoration procedures or complex defects. Oops. So on this cartoon, there's this, what I call the spaceship. It's a piece of equipment where we can get an entire femoral condyle from a cadaver or a person who is an organ donor, matched to size and age most closely. And on the back table, we can core out a plug of bone and cartilage that matches the size of bone and cartilage that we want to replace in the knee. We take that plug and then we core out the bad bone and cartilage in the knee, and then we put the plug in what's called a press fit, lightly mallet it in, line it up, and then we reestablish that defect. This is a very nice procedure, and it's actually gotten better a little easier because now we don't necessarily have to order an entire Henny condyle. We can actually get previously harvested plugs that are fresh or fresh frozen that come in a pre-sized diameter. And so if you have a pretty confident situation where you think you know the size of your defect, then you can order them off the shelf, and it just saves a lot of work on the back table. Oats are taking it from someone else's body, taking it from another location in the knee. We can take plugs from a non-weight-bearing surface and move it over in what's called a mosaic plasty. I think this technique's probably fallen a little bit out of favor, and it's limited by size because you can't take lots and lots of plugs from a native knee. MACI, this is what's called MACI. It was approved last year. It used to be called ACI. This is a significant improvement in the surgical technique, the time to surgery, or time in surgery, and then the overall recovery for these patients. And so what happens, this is a two-surgery procedure. We go in first with the scope, we diagnose the lesion, we take a biopsy of cartilage off of the notch, we send that biopsy to the lab in Boston. They culture and grow over a course of 6 weeks or as long as we need, up to 2 years. We can come back, the cells are implanted into this membrane. They're sent back to the operating room a day before the surgery, and then we can do arts and crafts, I like to call it, and literally cut a shape that matches our defect from the patch and glue it in. It's a really nice technique. Previously we had to sew it in, and you can imagine if you had a very large lesion and you were trying to sew in with what's called a 6-0 mitral suture, which is basically as fine as hair. It can take a long time to sew the patch. So now we can glue the patch, and it really has taken hours off the surgery. So it's been great for everybody. So again, the biopsy, this is the patch, the picture of the patch, just to kind of give you an idea of what it looks like. And then this is an example of a case I did. This was an operating room nurse. She had a large condyle defect on the medial femoral condyle. And after we prepared the lesion, you could see that it was very oval, but it was large. And it's in the weight-bearing portion of her knee. And we went ahead and did the technique or the steps that you saw, and you can now see the patch glued in on the femoral condyle. So it's a really nice procedure. We had to do this open, obviously, because you got to have exposure and you got to be able to see what you're doing there. Athletes get back to sports with cartilage restoration. Therefore, I think injured workers can get back to sports, or get back to activity and get back to work. You can imagine that if you're doing a cell-based treatment, that it's going to take longer for those cells to grow, take, and for the injured worker or the athlete to rehab. If you're doing a plug where you're plugging it in and you already have the cartilage that's mature, they can come back quicker. So an oats or osteochondral allograft procedure is much quicker overall. And so there are factors that influence what we can do here. Defect size, so the smaller the better. Symptoms that last less. No previous surgeries, younger age, and then again a higher pre-injury level. So those are kind of some positive factors. There was a survey done for NFL team physicians in the sports literature that they asked the 31 physicians what their factors were that came into their decision making, and size, and then the treatment choice, which was microfracture, debridement, non-operative, the autograft or allograft, or this ACI. And again, I think microfracture is the most popular because it's the easiest to do, and when you don't know exactly what you're getting into sometimes arthroscopically, when you see it, it's very easy to do because your tools are there. So in conclusion, it's important to differentiate between meniscus and articular cartilage pathology. We like to get a complete history through some x-rays and MRI. We may not know the articular cartilage status or injury until the time of arthroscopy. MRI can underrepresent articular cartilage injury. And then surgical management is multifactorial and based on multiple factors. There are good results. So let's talk about a couple of cases to kind of illustrate this. All right. So How do I approach this type of patient? I need to identify the chondral lesion, the size, and the location. I need to consider their activity level or their occupation. And then I need to think about, of all the tools in my toolkit, what's best for this patient. And then I have to also think about, if I'm going to go forward with a major cartilage restoration procedure, do I need to protect my repair? And the way to do that would be to do an osteotomy. So we have to be aware of alignment in people's knees. And alignment can be from the front, can be from the side, or it can be how your kneecap glides on the front of your thigh bone. The most common osteotomies performed are the high tibial osteotomy, otherwise known as the HTO, and then the tibial tubercle osteotomy, otherwise known as the TTO. There's other names there you may have seen in some of the literature and notes as you guys have gone through these cases. But basically, for the high tibial osteotomy, we are going to cut through an open incision the proximal tibia across, and we're going to gap it open a certain number of degrees. For someone that's in a bow-like position, if we can change the alignment of their knee and get them to where their weight-bearing axis goes through the center of their knee and not on the inner part of their knee, if we're trying to protect something on the inner part of the knee, we can consider an HTO. If the problem is underneath the kneecap or where the kneecap glides, we can cut a triangular wafer of bone off of the front of the tibia, and we can shift where the kneecap inserts and take pressure off of the kneecap in the patellofemoral triangle. So again, a couple of cases to give you an idea. So this was a recent case of mine, 35-year-old laborer in shipping and receiving. There was a heavy pipe that went to fall. He tried to catch it, his knee bent, he felt a twist and a pop. He had significant swelling, and ultimately he dislocated his kneecap. So his kneecap went, as we know, it's central in our group. Normally it went out laterally. So it completely dislocated laterally, came back in. And so depending on the position of your knee when this happens, and depending on the force involved, you can get significant cartilage injury underneath your kneecap with this. So from a kneecap dislocation standpoint, you can have a simple, where it goes over and comes back. It stretches out the ligaments on the inner part of the knee, but we can treat that typically with therapy, get it better, and in an older patient who's already a little more stiff in the knee, I think they heal up just fine. In a relatively younger patient, if there was a cartilage defect or a chondral injury, then that's an automatic surgery because typically it's a loose body, and typically something needs to be done to restore the cartilage. And in this guy's case, he knocked a huge piece of cartilage off of the lateral femoral condyle as the kneecap shifted over. It sheared a large piece of cartilage and bone right off. So what we did was, I don't have his MRI, it was on an outside disc, and I wasn't able to get a picture, but I've got some good scope pictures. We went in on the first surgery, and we put the camera in to diagnose the problem. And there was enough bone on the back of the sheared off piece of cartilage that I was able to fix it. I was literally able to pin it back into place. And bone will kill the bone, but a cartilage won't kill the bone. So that's why I did that on this case. At the same time, once we were done with that, we tightened up his inner, what's called the MPFL, medial patellofemoral ligament, to hopefully help prevent a future dislocation event. He got really stiff despite adequate physical therapy. We had to manipulate him under anesthesia. I'll show you a picture. And we scoped him again. And with therapy, time, and some TLC, he made it to MMI and back to work at about 9 months. So here he is. Again, I don't know how it's projecting. Here is the large fragment of cartilage that sheared off. There's bone on the back here. And this is the lateral femoral condyle where the piece sheared off. So you can see this big base, this big pothole here, this big defect. Okay. On the back table, I took it out of the knee. There it is. It was sizable. We had to inspect it, make sure there was enough bone to work with. And then we went ahead and did an open repair. So here's the pothole now. There's his kneecap. We made a lateral or outer arthrotomy, a window to go into the knee. And I don't know if you can make it out, but there's a couple little holes in there. There are these very small, plastic-looking, almost real small drywall screw devices that we can use as little nails that we can pin these fragments back into place that the body will then grow into over time. So that was the repair of the fragment. Better to use his own tissue if we can versus going through some big rigmarole procedure later. I tried to blow it up and see, I don't know if it makes any difference, but that's the piece fixed in place. Here's another, here's a scope picture at 3 months. Whenever I manipulate somebody, we put them to sleep. I bend their knee carefully so I don't break the tibia trying to bend the knee. And then I always scope and I put the camera in to double check and make sure we get all the adhesions or any of the scar bands out. Not to mention, it's nice to take a look and see, is the cartilage repair healing? And it did. It healed up very nice here at 3 months. So I was really happy with how that looked. There was no instability along the edges. You can see it healed over very nicely. Here's our manipulation photo. I always take a photo in the operating room. I take a before and an after. I think it's very important for the patient to see that their knee can bend that far, or in the case of a shoulder, that the shoulder can move that much. And obviously we can learn a lot doing manipulation under anesthesia with some of these patients who come into the office and can't move their arm and can't move their arm, and are in too much pain to move their arm, and then we put them to sleep and then their arm goes right up and there's no problems. That's a kind of a red flag for me, and I know I've made some phone calls to some of you in those situations. In this case, he definitely was stiff. He would not bend past, almost 90 degrees. After we bent it and felt the crack pop of the scar tissue breaking, we got him out there at about 125, and it's really helped get him over the hump. Here's another case. This is a 53-year-old laborer. He's coming off a ladder. He had no pain, no problems in his knee prior to the injury. And all of a sudden he went from this step to a swollen, painful, locked up knee. And I want to show you this x-ray here. So something's not right here on his medial femoral condyle. You can see the normal smooth borders, perfectly pristine knee otherwise, but he's got this almost sharp bite here out of his medial femoral condyle. So this was an OCD or osteochondral defect case. And here's his case. Here's his scope pictures, and you can see this large chunk of cartilage here that was unstable and obviously causing the locking. This is not salvageable, so this just got debrided out. You can see the bone here is pretty sclerotic, meaning this has probably been there for a little bit. So that's obviously something we can talk about in this case, but he had an OCD that I think was there that ultimately became unstable with the step off the ladder. And the question is what to do for this gentleman at 53 with an otherwise normal knee. So we did one of those off-the-shelf plugs. So because his MRI was pretty solid, it was very accurate, I felt that we can move forward with this. So this is the pre-made plug. It doesn't fit perfect. Sure, maybe we could have maybe a 12 or a 15, but I thought that this actually was a very good fit for this. And in this little area here, we just kind of drilled a couple little holes with a little K-wire, stimulate a little bleeding to get some scar cartilage in there to kind of bridge the gap. This guy did great. We just protected him. He was asking me to walk quicker. I was trying to keep him slow him down a little bit, but he did some therapy. Seemed like a pretty straight shooter to me. Came back 3 to 4 months and I'm ready to go back to work. And so it was a great illustration of one of these osteochondral allograft procedures. Here's another OCD, 35-year-old. You can see this flattened area here on his condyle, almost like a little shark bite here. Here's his MRI. So you can see this missing piece. That corresponds to the area on the x-ray. A lot of fluid in his joint, very aggravated knee. We took a mechanical axis, which is what I was alluding to before. So we take an x-ray from the hip to the ankle, we drop a plumb line, and lo and behold, his weight-bearing axis ran right through the OCD lead. So I felt like if we were going to go through a big procedure for him, we should do an osteotomy, because that would give his cartilage restoration the best chance of success. So we do some preoperative templating and planning, and we measure an angle right here. And so when we make our cut right here, 1 degree corresponds to 1 millimeter here, and you'll see that we were able to correct them. So I went into this case looking to scope him, do the HTO, and do the Oates procedure. Here's the appearance of the area that you saw in the MRI. Pretty nasty looking lesion. This one was done with the spaceship on the back table. So you can see the femoral condyle right here, the plug taken out. Here's a picture of the plug. You can see all the equipment on the back table for this kind of case. Here's us doing some finals. So this is a plate and screws. This is the osteotomy site right here. And then here's the plug that we put in to match the contour of his condyle. Here are post-operative x-rays. You can see out the plate and then the wedge, and then we put some what's called bone graft in here. And this is both our front and our side. He ended up doing very well. He had a lot of anxiety issues, and some other things going on, but ultimately he did very well. A firefighter, 23-year-old, multiple patellar dislocations, can't do things he wants to do. Kneecap sitting way up and lateral. He's got this little bone chip here too on the medial border or inner border of his patella. We got an MRI. Here's the cartilage on his patella, but then we have a big pothole right here. Big swollen knee. And you can see how the kneecap sits lateral. It's translated relative to the edge of the femur. So a lot of problems here to correct. So we're going to go in and scope him. This is the case that needed the tibiotubercle osteotomy. I used a different type of cartilage restoration called de novo on this one. We took that patellar fragment out, and then we tightened up his kneecap. So here's the nasty looking cartilage defect underneath his patella. Here's the fragment that you saw in the x-ray that we took out. These are the cartilage cells called de novo. They're juvenile articulated cartilage. I've gotten away from using this, although I think it's a good product. I just like the Macy technique a little bit better. And then here we are working underneath his kneecap. Sorry, that's a little blurry. We prepared the lesion. Again, on the back table, getting the cells. And then we call it the booger. We kind of use this glue that's kind of snot-like, and we just plug it in there and it'll dry. And then it firms up. So that was the cartilage transplant. We went ahead then and realigned his extensor mechanism with the 2 screws. So I can move things medial or inner, and he did very well. I think there's about one last case, and then obviously let's leave some time for questions. A football player, he had a kneecap dislocation. I feel like I've seen a lot of these lately, these patellar dislocations. Large loose body, came off right here. Here, big swollen knee. Went in on his first surgery, took the piece out. Tried a microfracture on his kneecap. It's technically challenging. The angles aren't good. It's tough to get the picks to go up on a kneecap that moves around on you. We went ahead and tightened up his MPFL, and I did take a biopsy to come back. Here's the chunk of cartilage in his knee. Here's looking at it. You can see how thick cartilage can be when it shears off. Here's the defect where it sheared off. Here's all the stuff we took out of his knee, which is a lot. 8 months later, though, he was having problems with his kneecap, couldn't do sports and had swelling. So then we got him consented and got the cells growing. And this was done with the old ACI technique. But in the interim, he developed this lesion, or this lesion progressed from the first surgery. So he's got kissing lesions. He's got one on his thigh bone, he's got one up here on his patella. Here's his patella lesion. So this was another one of the TTO cases. This is us. You can see how we have to use an x-ray machine. We got to get in here and get the pins in the right spot and realign it to proper distance. He tried the microfracture did try and heal up here. It's good globular scar cartilage. So we had to take that out. We'd use this high-speed burr to kind of get down to good bone. On the back table, this is the old arts and crafts, which took a long time. So again, you have to do a template. Cut out a piece that matches the size. We just literally sew this patch in. You can see these little purple sutures right here. Takes a long time. And then you can see the 2 lesions that we did, P and T, P for patella, T for trochlea. And then the cells used to come in this test tube, and you literally had to pull them up in a syringe from the representative of the company, and then you had to inject them underneath your patch after you had a good seal so that they didn't just run all over the field. And then we went ahead and tightened the screws down, and here's his x-rays. So there's a big algorithm on this, but basically, this is exactly what I've described. There's a number of references I use. This is a little bit of information regarding my team. I have a team approach. I have a physician's assistant or PA. I have a surgery scheduler, and I believe strongly in athletic trainers as physician extenders. So they're the patients, they're the employees that room the patients. They can do some evals, they can fit braces, they can fit crutches, they can take stitches out, they can do everything that we need them to do. So I have a team of athletic trainers that we use for the clinics. So there you go. If there's enough time for questions, I'm happy to try and answer some. Go ahead, your hand first. What was the first procedure? Oh, the autograft. So compare the autograft to the MACI in terms of the time of treatment and what's involved. And long term. So a little bit of it depends. So let's say we have a great MRI, it's pretty obvious what the problem is, and I can say let's do an osteochondral allograft transfer, let's get that plug like you saw in that one case. So that's one surgery. Takes about an hour to an hour and a half, pretty quick weight bearing, and I think like I illustrated in that one case, I think most people do pretty well 3, 4, 5, 6 months because we can get them moving a lot quicker, the quad doesn't atrophy as much, they're not protected weight bearing for extended periods of time. The MACI, if done properly, 2 surgeries. So the first surgery is the scope and the biopsy, and then we have to go through this whole process of trying to get the second surgery approved. And then the lab needs at least 6 weeks to grow the cells, or a couple weeks once we give them the green light. So in general, you're already looking at a couple of months between the first and the second surgery at the minimum. And then they have to be protected weight bearing. And for some of those MACI cases, it can be 6, 7, 8, 9 months, and even sometimes out to a year overall. Because you're getting basically cells, microscopic cells, to grow to cartilage. So it takes a long time for that. Whereas those plugs, the cells, the cartilage is already mature. So the plug, I think, is a better route to go. The problem is its size, shape, location. Plugs work great on the medial lateral femoral condyles. The contour is perfect. Plugs are a little tougher on what's called the trochlea or the patella because the trochlea has a V shape, and then the patella obviously has a little V shape. And so to get those plugs to match in those areas are a little trickier. So it's got to be the right location, the right lesion, and ideally the right imaging to know what we need up front. If we have to come back for a second plug surgery, I think that's ideal for someone like an injured worker. Let's say we go in, MRI just didn't give us great information, we see it, this is a great case for a plug. Okay, we're going to go through the plug approval process, and hopefully we can get that patient back once the second surgery is approved. It's hard though, sometimes once they're off the table, getting them back for a second surgery can be challenging. I don't know if that answers your question.
Long term.
Oh, long term. There's really good long-term results for MACI. The plugs, I think, do very, very well out 10 to 20 years. MACI, some of the long-term studies out to 10 years, some of the cartilage centers around the country that do a lot of this every day. Patients do well out to 10 years, 10, 15 years. So it buys a lot of time. Does it last forever? Does anybody need last forever? I mean, sometimes no. We can all get some arthritis down the line typically. So, but I think it gives you a good option for a good period of time. Yes?
Have you encountered a lot of difficulty with workers' comp insurance or just the group insurance standards or the NACI procedure? And so why do you think that's happening?
Definitely. From a commercial insurers, they have policies on these. And I'm not sure the policies are written by orthopedic surgeons, but some that I feel like they're written by whoever's writing them. And no matter what I dictate, the pictures I take, the documentation I provide, they always seem to find one thing that they doesn't meet their policy. So then we have to go through this peer-to-peer process, which is arduous and painful. So I wait online, or wait on the phone, excuse me. I'm lucky to get someone after a while, and typically it's a primary care doctor who says, I'm not authorized to make this decision. I need to get you a matched peer-to-peer. So then they have an orthopedic surgeon, and then I have to go through that again at another time. And if I can get an orthopedic surgeon on the phone, a reasonable person, I can explain what I'm doing, it usually gets approved right away. But it's just a process that they like to dig in. They also like to rule out age. I've had a lot of younger patients recently with these, we're doing these MACIs on, and they like to say, you know, it's a pediatric patient, this is not approved, even though, yes, they're under 18, but their growth plates are closed, they're teenagers, and I think it's a perfect procedure for someone like that. From an injured worker standpoint, yes, it can be a challenge, but again, I think if the documentation's there, the science is there, you know, we've turned everything in the best we can, and this is our plan from day one, then I think we can get it through. It just sometimes requires some people talking to me, me talking to someone from the insurance company. So. It is, yeah, so there's a cost, sure. So growing those cells and sending them back and reimplanting that, it's not cheap. But it's the patient's own cells, it's one of the selling points. Yes?
So, when we compare patient population, if the average NBA player for this year is 26 years of age, they have access to full-time physical therapists and personal trainers, basically whenever they want, 40 hours a week, 24 hours a day, whatever they need.
Good point.
And then, could you kind of direct our attention to some of the follow-up studies of NBA players that in their 50s and 60s, to see how they've done 15, 20 years after they've left? Can you tell us anything good in those studies?
I mean, I can't give you a specific, I don't think they've been followed out for the 50s and 60s, but I think a lot of them have ended up with unique compartmental replacements, multiple surgeries, some debridements, sometimes even total joints, I think by the time they get to the 50s and 60s. In general, I feel like pro basketball is hard on knees, in general. So I don't have a specific study I can quote you, but there's usually some downward trajectory on those as they get older. Yes?
How frequently do you use a surgical assistant during a procedure, a more complex procedure? And how, during your deposition, do we ask you the question how to justify, I don't mean this in a pejorative sense, to justify the need to have a surgical assistant so when we get to that bill denied, that's why you get that case.
Good question. So one of the individuals in my team photo is my physician's assistant. So she is in every surgery with me, and she also runs her own clinics alongside of me. There are other surgical assistants out there that I would use from time to time if Sherry's not available on vacation, etc. How do we justify it? It's hard to put it into words other than it is someone who's ultra reliable, who's necessary to position the patient for you, position the exposure, hold the retractors, in some cases put a screw in, depending on what else I'm doing. They prepare the grafts on the back table in many cases. So they're extremely important for whatever needs to be done in the case. Usually the patient, we try and get it paid for, particularly from a commercial standpoint, whereby, patient BMI. So the patient has an ultra BMI, they're hard to move around, and their leg's heavy, we need someone to hold the leg, we need someone to expose everything. But hopefully the surgical assist does almost everything to make my life easier. I couldn't do some of these cases without the surgical assist, or in my case, the PA. And in some cases, depending on the day and the way the day is flowing, having that trusted assistant to do everything, make sure takes the anxiety down a little bit. Any other questions? Oh, you're easy on me.
Thank you guys for having me. Appreciate it.